My name is Jean-Pierre Leung. I'm a family physician, member of the South Calgary Primary Care Network, or SCPCN, and I'm the medical lead for chronic disease management. So, as a physician, change agent means a number of things to me. At the population level, I see expectations of primary care being a huge challenge for us unless we change the way we've done things. And that trickles down to the clinic level and to the individual physician and his panel and his team. To me, I emphasize team. The needs of patients are getting more complicated. We are becoming more overwhelmed cognitively, where there's more to do in each visit. Patients are perhaps more sick. There's a lot of work to do. And ultimately, the vision of having and maximizing the scope of practice of every professional, to me, has made a lot of sense and just resonates with me more and more every day. My role, especially with change, the vision, right? That change from the physician-centric model to a team-based approach. Yet the team members themselves don't necessarily perceive that, and so I think it's essential that the physician actually leads that culture change, bringing the vision, be it to us at a granular level, to meetings, and saying that we're now actually establishing a different dynamic here. We're all team members, we all have our expertise, we all have our values, and we're all going to be valued the same way, and we have to follow through. So that's where I, as a physician, have to support. I've got to support that collaborative model. I've got to support individual team members who think they need a knowledge gap filled, or some other sort of educational component that I can provide to them as an expert within the physician realm. Beyond that, though, the richness that you get from a synergy of different expertise, you've got the richness of the interaction with the patient. Ultimately, I think that brings patient care to a high level, and that's what finally is a success for the team, and that we just build on that. So valuable learnings for teams that are starting like us, engaging in this kind of work. Meetings for us were central, establishing that collaborative tone. Coming from the physician was something that we learned actually was pivotal, that he or she sets the vision and establishes that this is a change of culture, that the agenda was specifically ordered to have the physician speak last on any issue, but that we addressed all issues of all team members on the agenda, and that the physician really was only an expert within the physician realm. The way we implement it during the meetings carries through the day-to-day. The follow-through involves a very democratic approach, a collegial approach. The collaborative aspect, though, is really, I think, the essential component to this. We found that patients expect it, and we just have to actually change our perspective. Over time, we discovered further that we were gaining successes. Our confidence as a team was improving as a result. We were discovering assets and skills that we were just incorporating naturally as individual team members without necessarily leadership from the physician. This could be emphasized to any team at any stage. Things take time. One must be patient, and one must be patient with failures and consider them, obviously a platform for success. Occasionally, that might involve identifying a team member that really isn't able to fit into the team. That's a rarity, I would hope, and I find in healthcare especially, we are all in it for the right reason. And on that, finally, I'd say that really one must always keep in mind that patient care comes first. and that our efforts are all going in that direction, and we just do it one day at a time. A defining moment for me was when we were trying to implement our pain management protocol. My traditional approach would have been to do everything more or less by myself, and I struggled with that, actually causing waits at the front desk, plenty of challenges in terms of just trying to get through my day. And I realized that ultimately we had to really just take advantage of the scope of practice of all our expert colleagues. When we implemented our pain protocol, I encountered a barrier. I initially misperceived that as a knowledge gap amongst the nurses. In fact, it was just follow through from the meetings of that multidisciplinary approach, which was still foreign and not absorbed by them. And we overcame that barrier by having corridor consultations, closing the loop on specific cases that were learning issues, and we were able to build on those successes. And within a few months, we noticed that the nurses actually were taking initiative and were actually evolving the protocol beyond what we had actually discussed during the meetings. What is next for us is really based on whatever our patients need. Currently, we are going to we're really planning in the short term to expand our chronic pain management to increase, to welcome other team members, so that would be mental health, as well as possibly even a pharmacist. And we've got that foundation, we feel, already. So it's really much more positive, less uncertainty in some ways, and yet more enthusiasm for where we can go next. We've actually already leveraged what we've got to establish a very, very consistent mammography, colonoscopy, hepatitis, and aortic aneurysm screening. And that's already ongoing. And so, since we've talked about this, it's actually really already expanded to those programs.